Can I request Lakshmi ma'am, Ramesh sir and Kiran sir to please take the next session. We'll have Dr. Sham present in the next case. We'll have it at 45 minutes. Sham. Thank you. We'll try to stretch if we can. Thank you. You can start with the patient, please. Good afternoon.
They will start.
Sir, can you start, sir? Yes, sir.
Good afternoon, sir. So, 18-year-old male patient, resident of Kharagpur district, West Bengal, student and staying in 12th standard, coming from a low socio-economic class, presented with the complaints of bluish discoloration of skin and mucous membrane since 3 months of his age, easy fatigability and dyspnea on exertion since 3 years of age, and chest pain and palpitation since last 8 months. Informant is patient and his mother. The treatment history is little not reliable because during the follow-up, father used to with the patient and he lost his father 8 months back. HOPI. Patient was born of non-consensuous marriage, full-term normal vaginal delivery, cried immediately after birth, and was asymptomatic till 3 months of age when he noticed to have a bluish discoloration of skin and mucous membrane by parents, which used to get exaggerated on drying, feeding, and was reviewed by partially by the rest. For this complaint, parents consulted a doctor and diagnosed to have a congenital heart disease and advised to visit a tertiary care hospital, but due to financial constraint, they were not consulted. No, sir. Cyanosis was persistent after persistent. 3 months it started, so thereafter it persisted. Patient also had episodes of deepening of cyanosis when he was around 2 years of age, which was precipitated during exertion like running and was associated with increased rate of breathing, restless, and get relieved with squatting. These episodes were frequent till 3 years of age, which they become infrequent, and bluish discoloration was fixed as noticed by the parent. Patient also history of easy fatigability along with a dyspnea on exertion since 3 years of age, which was insidious in onset, especially on exertion, and partly reviewed by the rest. Dyspnea on exertion was initially running and playing with the same age group of children, climbed more than 2 flights of stairs, suggestive of NYHA class 4. For this complaint, parent consulted a cardiologist and advised a surgery. At 4 years of age, patient underwent a surgery, and parents were counseled regarding may need a second surgery in future if required. Mother not remember any angiogram was done before surgery. After the surgery, patient was prescribed one tablet which he continues to take till now. After the surgery, the bluish discoloration is decreased but is not completely gone. Dyspnea of class 2 were persistent. Later on, patient lost to follow-up. Since last 8 months, there was increased dyspnea as progressed to the NYHA class 2 to 3, such that he is unable to ride a bicycle and even can't climb a 1 flight of stairs, suggestion of NYHA class 3. For this complaint, again he visited a cardiologist and underwent an echocardiography test and told that he required a second surgery, and currently he is admitted for a surgery. There is no history of any recurrent LRTI or heart failure symptoms. He is also complaining of palpitation associated with chest pain. His palpitation were regular in nature, gradual in onset and offset, not associated with post-palpitation dialysis, occurred on exertion, such as riding a bicycle for more than 200 meters or climbing a fast-way through flight of stairs. Suggestion of MYHA class 2, and palpitation is associated with dyspnea as well as chest pain. Chest pain is also complaining occasionally associated with palpitation, which is of retrosternal, constricting, diffuse type, non-radiating, and relieved after taking rest. There were no history of any BND, orthopnea, or syncope. No history of any abdominal distension or pedal no history of long-standing fever or any infective endocarditis feature. No history of diminution of weakness in any limb. No history of headache, giddiness, or lower limb ulcer. No history of any phlebotomy in past, and no history of hemoptysis. Birth history.
Can you just summarize that once?
Yes, sir.
The relevant points.
So 3 months of age, he diagnosed, means he developed a cyanosis. Thereafter, it was persistent. Then he developed dyspnea and fatigue at the 3 years of age. At 4 years of age, he underwent a surgery. Later on, the surgery told by surgeon it required a second surgery might be. Then last 8 months, he is having a palpitation and chest pain, and dyspnea is increased from class 2 to class 3.
What is class 1? MYHA class 1.
Sir, MYHA class 1 patient with the cardiac disease. Without a limitation of the physical activity. Ordinary physical activity does not causes any fatigue, palpitation, angina.
What is CCS class 1? Because it does just pain.
CCS is more of a difference is that it also occurred in class 1 the sternus activity. Also more defined like walking one block or climbing stairs compared to the environment. So class 1 is patient with Canadian cardiovascular system classification for the chest pain.
Yeah, that's one of the fundamental differences. In the Canadian classification, it's actually specific on sternus activity.
Is also included.
Whereas MYHA only says ordinary physical activity does not produce symptoms, and what happens with more than ordinary is left unsaid. So that's one of the limitations of MYHA. Okay, so can you think of any conditions which fit in your history so far?
Yes, sir. I'm thinking of a decreased pulmonary blood flow like situation. That too at the 4 years of age, he not underwent a complete repair. They told that it requires second surgery. So more sort of I'm thinking any complex heart disease that requires some sort of palliation that might require a second surgery. Likely top variant like DORV, PSD, PS, where PSD is unrootable, or single ventricle PSD, PS could be, or it could be an unbalanced ABCD with PS, or heterotaxy like syndrome.
What value
Sir, after analyzing all, I'm thinking it's likely a Glenn surgery.
What surgery?
Glenn surgery.
Jensen.
It's Glenn.
Why not a VD?
So it could have been done earlier, sir. Like VT be done when there is severely decreased pulmonary blood flow, child is more symptomatic.
But Glenn also don't do it. You said that surgery was in 4 years.
Yes, ma'am. Yes, ma'am. It was not ideal age. Child was lost to follow-up. He presented very late, like diagnosed earlier, but he came to like tertiary hospital at 3 years of age.
What is classical plan and bidirectional plan?
So classical claim we attach end to end. Directly we attach SVC to the end of the RPM. In the modified we attach end to side. There is bidirectional flow to RPA as well as LPA.
You know any indications? I mean, generally now top is typically go for ICR.
Yes, sir.
So any indications where they do VT chart?
Yes, sir. A second condition in which TOF also like underdeveloped LV or the PA anatomy is not good, not confluent branch PAs. In that case, we go for VT stent, like TOF with pulmonary atresia like condition. Then we can go for ICR like. So we have various scores like we use for Nakata index as well as a McCoon's ratio. So in Nyquist ratio, we do a summation of the LPI artery divided by the aorta at the level of the diaphragm. If it is more than 2.1, we consider as a good pulmonary artery anatomy. Whereas Nakata index we consider an area like R1 ratio, R1 square plus R2 square upon the cross sectional area of the lung. If it is more than 100 square centimeters square, considered as adequate for the ICL.
Palpitations were regular.
Yes, sir. It was occasional only on the exertion, sir. It's not arrhythmic, non-arrhythmic. It was only on the exertion. Specifically told on the riding the bicycle, likely might be more mixed or more high.
You also described the chest pain which sounded angina to me. Can you tell me some conditions where you get angina kind of pain in the same or in the pediatric treatment?
Sir, like anomalies of the coronary arteries, we can expect a typical angina type of chest pain.
Why should an anomaly cause pain? Can you elaborate a bit?
Alpha.
Alpha is a very major. How does it usually present?
So usually present with the heart failure, sir. And
What
then,
age?
in early presence, sir, like in children's.
At birth or later?
Later, sir.
Why?
So there is a PPR is high at initially, so not present.
Why do you get myocardial ischemia in Alpha? Is it only because blood is coming from PA which is relatively desaturated? Is that the reason?
No, sir.
What is the reason?
It's still like from LA, RC is directly getting into the PA, like
It's a
continuous.
steel.
Yes, sir.
So when the PA pressures are high, the steel is not there.
Yes, sir. Periods.
First later, but generally it happens at in pretty young age. Probably not if this is at 5 years later. The chest pain started after
Last 8 months of this.
last 8 months. So, do you know any other coronary anomaly which can produce myocardial ischemia?
So there are like obligatory ischemia and episodic ischemia. Episodic ischemia like myocardial breach, or obligatory ischemia might be origin is from the certain like Al-Kappa or from the other. Then there might be obligatory ischemia that can cause a chest pain.
Any other? Any compression?
Yes, the PA is very diabetic, that can compress the left main and can be.
So, if it is going between aorta and
Yes, it's retro.
especially if there is pulmonary aspiration also, it can get stressed. Any other conditions where you can get stenosis in a pediatric treatment or thrombosis?
Yes, sir. Homozygous, family homozygous hypercholesteremia, we get Australia's.
Audience, Kawasaki.
Kawasaki in
Kawasaki is probably aneurysms are common, but also stenosis, thrombosis, all these are.
Yes, sir.
So, what do you feel is the cause of the chest pain? Do you feel it is angina?
Sir, on the exertion it is present, likely it's a cardiac origin.
And this has started relatively recently. He is now 18 years old.
Yes, sir.
What is the cause of dyspnea? Is that during the
Cause of dyspnea in this case might be any systemic ventricle failure causing dyspnea now also. Initially, sir, with more sort of like fatigue and dyspnea exertion, both were telling at segment family included both. It's more of fatigue, sir.
These top patients also complain of what is the cause?
So fatigue is because of the hypoxia more of.
Your history is not over.
Yes, sir. So birth history is born of non-consensual marriage, full-term normal vaginal delivery, tried immediately after birth. Birth weight was 3 kg. Maternal history is no history of diabetes mellitus or hypertension or other major medical illness in the mother. No history of fever or skin rash. No history of smoking or alcohol intake. No history of any drug intake in the mother for like treatment like epilepsy or psychiatric illness. Developmental history, motor.
Which drug are you specifically?
So phenotime, carbamazepine or antipsychotic like drugs like risperidone or anticoagulant like warfarin,
Lithium?
lithium also, bipolar disorder, extreme animalism, extreme animalism. Developmental history.
Why alcohol?
Yes, sir.
You said alcohol, right?
So alcohol also.
With what? Fetal alcohol is that warfarin, ampliopathy, all these are very well known conditions. Okay. And any maternal illnesses, fever, febrile illnesses?
Developmental history, the motor and the gross motor and the fine motor are normal. There is no developmental delay. Family history, there is no history of sudden cardiac death. Two siblings, younger is of 12 years old and is healthy. Personal history, consumed meat diet. Appetite is normal. Normal bowel, bladder and sleep pattern. No drug allergy and no addiction. Summary. 18-year-old male patient, cyanotic congenital heart disease. Diagnosed at 3 months of age, likely a decreased pulmonary blood flow. Underwent a palliative surgery at 4 years of age. They lost to follow. Now since last 8 months he is having a left-sided symptoms like increased dyspnea and palpitation, likely due to any systemic ventricular dysfunction or AV valve regurgitation.
You did say some frequent respiratory infection.
Sir, I mentioned there is no frequent history.
No frequent.
No.
So what are your possibilities?
Sir, I will think of first is to be a top variant like DORD VSD PS where VSD is not rotatable, single ventricle VSD PS or unbalanced ABCD with PS or any epilepsy syndrome. But it could not be a straightforward top because at the 4 years of might underwent a direct ICR. So it could be a top with the other possible like underdeveloped LV or any wall reagitation or something or P anatomy is not good. Or it could be a tricuspid atresia with like 1B or 2B. Yes. General examination. Patient is comfortable and cooperative. Height of 181 centimeter. Weight is 55 kg. PM of 16.8. Arm span is 185 centimeter. The ratio of arm span to height is more than 1. There are skeletal features. It is very tall compared to some orthogonal features were there, but there were central sinus,
So upper segment, lower segment region.
Yes, sir, it's normal. Only arm span is exceeding more than the normal size. At 186 and height is 181. 5 centimeter.
Which landmark do you use to say upper segment?
So synthesis.
Synthesis.
There's grade 3 panistical clubbing, central
So
sinus.
you're saying he is tall, he has half-human features, but the upper segment, lower segment doesn't fit in.
Yes, sir.
What about other things? What else do you look for? Other
Is it-
Because you said he has those features.
Yes, sir. In clinical examination, we can see for arch, high arch palate. We can see for facial abnormalities.
Right.
Dolichocephalic, they mentioned, broad head, tall head. And apart from that, we can see for hand foot deformity, flat foot. Arachnodactyl is finger, spider-like fingers. Wrist and thumb sign is there, sir. He is having this.
You did mention it.
What is the criteria?
So we use modified gain criteria to diagnose the modified gains.
What is gain?
Gain.
It's a place.
Name of a person. Name.
You need to send it to the
Back and span examination often no gain.
You look for anything in the eye.
Yes, sir. I look for hydrogenesis. It shows vitals after that pulse of 82 per minute regular, normal volume and character, no radiovascular or radiofemoral delay. All peripheral pulses are verified.
Where do you get radial delay?
So in shunt, like if we get a VT shunt, classical VT shunt, then that we can use. Or sometimes like supraorbital radius because of.
And you get, once the radial delay, radial option.
Yes,
No delay option.
Sometimes you get excellent collaterals. So where you could get sometimes, but usually the pulse may not be. It's difficult to be. Yeah, you said supra.
Supraorbital radius.
What happens there?
So jet is preference to go towards the right.
What's that called?
One So supraorbital radius. So we getting Williams syndrome, hypercalcemia. Yes, sir.
On the left side is lower.
Right side is higher, sir. Left side is lower.
Yes. Supposing I say jet is directed towards left side, top of the windshield effect, and left side is lower, then will happen. Can be moved. Can be speaking of.
No, what about super AS, that will be also oscillation of the started oscillation of the
Yes.
coronary responses, and also the custom of the coronary and the carotid. So can
What is this venturi effect you were talking about?
Yes, sir. Meaning after the high flow state, escaping from the narrow space, there is a amplification peripheral.
There is a low velocity, the low pressure area adjacent to the high velocity jet. As the velocity increases, pressure decreases. But that can be seen only adjacent to it. Not be seen beyond that. The left upper limb and all that. It's not be seen there.
So blood pressure, left and right upper limb is 115 by 87 millimeter of mercury. Right lower limb is 140 millimeter of mercury systolic. Respiratory rate is 60 per minute, abdominal thoracic type. Saturation in all four limbs is around 76 to 78%. JVP is elevated 7 centimeter above the clavicle. The waveform is not able to regulate exactly. Just review it.
Open not there, open not there. It is engulfed.
Yes, sir.
JP is, I mean, full.
Yes, sir, full, sir. But waveforms were not there, sir.
Waveforms are not there.
It's a full only, I'm not saying on the top only, sir. Like positive only.
So you see it
Distended, non-versatile, like
non-vertical, intraventricular, on both sides.
it's where on both sides, sir.
Mike, don't know.
Yes, ma'am.
Did you hear the question?
No.
Repeat the question.
You have made a diagnosis so far before examination. What is the people are thinking go to your diagnosis?
No, ma'am. Like,
Okay, did you check both sides together?
yes, sir. I checked both sides because one side I was not getting, so left side also I tried to get.
And what did you find? Same.
So I
Distended,
no, yes,
high pressure, non-pulsatile. That means saying that there are pulsations on the left side.
Yes, ma'am. Yeah. Yes, yes, ma'am. Yes. Like pulsatile pain is going to be some antigrade flow is still there that could
It's not going to reflect elevated pressure so
In what condition you will find that only the left side is pulsatile? Here in a Glen, do they disconnect the innominate wave?
SPC.
No, SPC is connected to the PA.
yes, sir.
What happens to the one which comes from the left side? It's still connected?
If it is there, it will also connect.
So if the right side is non-pulsatile, left also has to be non-pulsatile.
Yes, sir.
Where can you get left pulsatile and right is not pulsatile? assistant LSPC. Back in my and sometimes due to various reasons, typically multiple cerebral cannulae, the intervention is almost also. Many of these patients would have long-term, more often seen in CKD patients, but even here, it's had a surgery. Mother to minds.
Cardiovascular examination, inspection and palpation combined. Chest is paraxial symmetrical, no precordial bulge. There is midline sternotomy scar. Apex pit is situated in the right fifth intercostal space. It's localized at midclavicular line. Medial retraction suggests of LV type of apex. There is no thick or parasternal wheel. Second heart sound is palpable in second right intercostal space. There is no suprasternal pulsation, no palpable S3, S4. Trachea is central. Percussion. Upper border of the liver device is marked in the sixth intercostal space on the right side, and defining node on the left side suggests of situs orbitus. Left heart border is retrosternal. Right heart borders correspond to the apex. Right second intercostal space is percussion, sir.
Apical impulse is where?
Right side.
Right side.
Yes.
Which space?
Fifth intercostal space. LV type. Oscillation. S1 is normal. S2 is single and loud, likely A2. There is no S3 or S4. There is ejection systolic murmur of grade 3/6 crescendo decrescendo. Breast heard in the right second intercostal space. Same murmur is also heard in the left second intercostal space. There is no murmur on the back. Only one murmur is this. Other system examination is normal. So, situs orbitus dextrocardia, cyanotic congenital heart disease with decreased pulmonary blood flow, like top physiology with LV type of apex, likely a single ventricle VSD. Yes, sir. History of palliative vein surgery at 4 years of age. On the basis of the what time they reach, like 4 years of the age they reach stent or some stent they have done might be running like in severe case.
No, but you said the patient won't take medical attention till that age now. So can you apply the normal age at which you do things?
No, sir. According to that, it's not. But severity is that much. 4 years also living is also risk.
Okay, some question from palliative study done.
Cytosolitis dextrocardia, cyanotic congenital heart disease with palliative surgery. Likely a single ventricle VSDPS, tricuspid atresia with VSDPS, with normal sinus rhythm in currently NYHA class 3 without congestive cardiac failure or IE features. So cyanosis is static, sir. We recently developed dyspnea and palpitation.
But surgery done early.
No, sir. Cyanosis decreased, but cyanosis will be there.
So left failure. Then thrombosis. Left failure.
Post vein desaturation or symptoms.
Why is the second heart sound single? What are the possibilities?
Likely a post aorta, and most of the blood is going to the aorta.
Because in status also destroyed. Could you be corrected TJ, VPTS and some palliative and some?
Yes, sir. That could be the possibility.
What you can explain any type of this?
Any type of ethics?
Corrected TJ. Because cytus solitus, they destroy. The statistically your corrected TJ will be more common.
Yes, sir. But CCTG is more of more symptomatic, like more of systemic ventricle is actually No, systemic ventricle is RV like more
How old is he?
CCTG.
How old is
He's
he?
he's 18 years old. CCTG, no? By 10, 12 years is usually like adolescent.
40 years. There is nothing there. If there is no BG, no case, then after 40 years, they develop, 40 years, they develop system ventricular dysfunction.
Well, it's because the AP and RV, there is orientation change in the muscle fiber. The circumferential fibers in the RVs are not there. There are circumferential fibers only in the AP, more of longitudinal fibers in the RV. So RV is not tend to be developed for handling the pressure. So it's used to have it and fail. Blood supply, so coronary blood supply, coronary flow reserve also missing.
So previous every time so electrically with the intrastate catalyst. Then
Possible.
transmission catalyst.
Possible.
Working electrically with the pressure attention.
Yes, sir. Type 2 yes could be possible transposition. Or type 3 or Marcos also possible.
Let's show that area.
Yes, sir. It was not diffuse, localized. So it's irregular.
You want to go to ECG or X-ray?
Like to go to ECGs.
Okay.